is my honor here today to be part of the AWE Art of Innovation course 2023. I'm honored today to be talking to you about the management of pancreatic fluid collections. These are my disclosures. So during this talk, we'll go over the classification of pancreatic fluid collections, the mainstay of treatment, which is drainage, talking about indications, approaches, and techniques, and then some additional considerations in terms of management. So starting off with classification, the first classification system in 1993 in Atlanta, Georgia became known as the Atlanta criteria, which classified pancreatic fluid collections as acute or chronic collections, and chronic collections were divided into pseudocysts or necrosis or abscesses. But in April 2008, it was determined that a better and more detailed classification system was required, and this classification system was revised, now known as the revised Atlanta criteria. And this criteria divides collections not just in acute and chronic, but it divides both acute and chronic collections into subdivisions based on the presence of necrosis versus just fluid alone. So the first type of acute collection is acute peripancreatic fluid collection, and these are collections that usually occur within the first 4 weeks of acute insult or pancreatitis episode. They have no solid component, and as you can see on the image here, they have no clear encapsulating wall. This is the other type of acute collection, the post-necrotic pancreatic fluid collection. Again, these usually occur pretty early after the episode of pancreatitis, usually within the first 2 to 6 weeks. They contain both fluid and necrotic debris, which differentiates them from the previous acute collection. And like before, they have no clear encapsulating wall. Then we move on to the more chronic collections. This is the first type of chronic collection called a pseudocyst. Usually happens about 4 weeks at least after the initial episode of pancreatitis. And as you can see, the difference is these collections are well circumscribed. They are homogeneous fluid collections without the presence of any solid debris. And here is the other type of chronic collection where you have walled-off pancreatic necrosis, which again usually happens anywhere from 4 to 6 weeks after the initial episode of pancreatitis. And these collections contain both solid and liquid debris surrounded by a clearly defined encapsulated wall. So when you have a fluid collection like this after an episode of pancreatitis, the mainstay of therapy is going to be drainage of this collection. But it's important to understand that just because there's a collection doesn't necessarily necessitate drainage. Not every collection needs to be drained. And the ones that really do require drainage are the ones that cause either symptoms or complications related to the collection. So for example, those collections that cause abdominal pain or early satiety, nausea, vomiting, or jaundice, if the biliary system gets compressed, those are the types of collections that require drainage. Similarly, if there's infection, probably the most common complication that we see, gastric outlet obstruction, biliary obstruction, or fistulization to nearby structures, then that would also be an indication for drainage. But it's important to note that size by itself, in the absence of symptoms or complications, is no longer a sole indication for drainage, and that was part of the revised criteria from 2008. So when we talk about drainage, there's really 3 ways that we can drain these collections. There's endoscopic drainage, percutaneous drainage, and surgical drainage, and we'll go through each of these in a little more detail. When we talk about endoscopic drainage, it used to be that there were 2 ways to do this, either conventional, meaning just with endoscopy visualization alone, or using endoscopic ultrasound-guided assistance. Initially, early studies looked like these 2 approaches were actually pretty equivalent when the collection could be seen bulging and from inside the stomach so that you knew where to target your drainage approach. However, newer studies have showed that actually using endoscopic ultrasound guided approach is associated with higher technical success and a trend towards a better safety profile. And nowadays, I think most of these collections that are drained using endoscopic ultrasound guidance. Percutaneous drainage can be efficacious, although when you look at it compared with endoscopy, this is a retrospective study of 81 patients showing relatively equivalent technical success and adverse events, but patients with the endoscopic drainage had decreased reintervention rates, shorter hospital stay, and a decreased number of follow-up abdominal imaging studies, which can be significant as these patients are getting quite a few CAT scans over the course of their disease process in order to track their response to therapy. Surgical drainage also is an option, can be efficacious. This is a study looking at direct comparison of endoscopy versus surgical cyst gastrostomy for pancreatic pseudocyst drainage. This was a randomized trial, 40 patients. And again, similar technical success rates and complication rates, but in the endoscopic arm, shorter hospital stay, lower overall costs, and better mental health and physical health scores amongst patients when they were surveyed after their therapy. So how to decide which approach is best? It's important to think about the location of the collection, the proximity to the GI lumen. If the collection is far from the GI lumen, then endoscopic drainage may not be feasible, and it may be better to proceed with percutaneous or surgical drainage in those patients. The maturity of the collection, if there's not a formed wall, then generally endoscopic drainage is not the best approach in those patients, and of course the expertise available at the specific institution. But in most cases, as you can see from the studies presented, endoscopic drainage is going to be the ideal first line approach. So when we talk about endoscopic drainage, what we're talking about is putting a stent between the collection into the GI lumen to allow the collection to drain and then subsequently heal. And there's lots of different options for the types of stents that can be used. There are plastic stents that can be used. There are the tubular, fully covered self-expanding metal stents. These can be biliary stents or in some cases even esophageal stents. And then of course, probably the most common is the lumen-opposing metal stents. And when you think about which stent to use, it's important to think about different factors such as the type of collection. Is this a pure pseudocyst with just fluid, or is this walled off necrosis? If it's just a pseudocyst, you can probably get away with a smaller diameter stent like a plastic stent or a tubular biliary stent, but if it's necrosis and you're anticipating that you may have to go into the collection, it might be better to use a larger diameter stent like a lumen-opposing metal stent. Again, similarly, if there's the presence of infection, that generally makes the contents thicker. You might be better off with a larger diameter stent as opposed to a smaller stent. The size of the collection, same thing. Faster drainage is going to be achieved with larger diameter stents. And lastly, the lumen to cyst distance. The lumen-opposing metal stents, the inner part between the two flanges is only 1 centimeter. So if your fluid collection is farther away from the GI lumen than 1 centimeter, then a lumen-opposing metal stent may not be the best option, and you may want to choose one of the other options in those cases. And this is just an example of what it can look like. Here you can see this is using a lumen-opposing metal stent. There you can see the stent being advanced directly into the fluid collection under EUS visualization. The first flange will then be deployed within the collection, as you can see on endosonography here. And then it will be pulled back against the upper wall, sort of as a retractor to hold that collection close to the GI lumen, which in this case is the stomach. And then the second flange will be deployed in the scope channel and then pushed out gently into the GI lumen, as you can see on the endoscopic image at the bottom right of the screen. And it's always very satisfying when you get a flush of material coming out as soon as you deploy that stent, and there you can see it. So sometimes in walled-off necrosis or those collections that have solid debris within them, drainage is actually not enough, and you are also going to need to do a direct necrosectomy. And what this involves is actually advancing an endoscope into the collection and mechanically debriding that solid debris, taking it with whatever tool is deemed best, and actually dragging it from the collection into the GI lumen. And this process can be very effective, but it is certainly not for the uncommitted. It often requires multiple sessions every 48 to 72 hours. These patients are generally managed inpatient for long periods of time, and there can be significant complications even in the most experienced hands, so it is important to have a multidisciplinary team available when embarking on necrosectomy. And this is just some studies showing that minimally invasive approach, starting with the least invasive and working your way up, is definitely the best approach for specifically for necrosectomy and walled-off pancreatic necrosis. This is an article from the New England Journal of Medicine directly comparing a minimally invasive approach, which in this case was percutaneous drainage, with retroperitoneal necrosectomy if needed versus open surgical necrosectomy. And what they found was that in the minimally invasive arm, there was actually a mortality benefit, less major complications or death, less long-term complications, and better healthcare resource utilization, lower overall costs. Similarly, this is a study from JAMA, again looking at endoscopic versus surgical necrosectomy for infected necrotizing pancreatitis. And again, the endoscopic arm associated with less major complications, lower post-procedure inflammatory response, which they measured by measuring IL-6 levels in the blood, fewer post-procedure fistula, less post-procedure pancreatic enzyme use, meaning better pancreatic function recovery post-procedure, and there was a trend towards a mortality benefit in this study. And what's exciting is that now, actually recently, we have a randomized single-center trial of 66 patients done in the US, where patients were randomized to a minimally invasive surgery versus an endoscopic approach. And while there was no mortality difference between the two groups, in the surgery group, there was a significantly higher rate of fistulas, 28% versus 0%. There was a higher rate of major complications. And when they had patients fill out quality of life assessment scores after the intervention, they were significantly lower in the endoscopic arm as compared to the surgical group. And this is just a video of what it looks like. Here you can see the scope is actually inside the necrotic cavity. You can see on the top wall there is a lot of solid debris or necrosis. And this is how necrosectomy works, taking a device, in this case a Rothnet was used, to literally grab the solid debris, pull it out of the collection into the GI lumen, and repeat the process over and over. And I like to, tell my fellows when they're learning this procedure, everyone has their favorite necrosectomy tool. In this case, a Rothnet is being used, but lots of other techniques can be used, such as snares can be used, trapezoid baskets. There's new devices now that can actually sort of vacuum up some of the necrotic debris, which can be great for that really sticky and thick necrosis that maybe is too slimy, for lack of a better word, to come through a device like this, but too thick to be suctioned. So an exciting area for sure, but certainly one that requires patience, as you can see, it can be quite tedious. And I will just stop this and move to the next slide. So lastly, I just want to talk about a few additional considerations to think about in the management of these patients. One is enteral feeding. This is a Cochrane review from 2010 that basically shows that enteral feeding versus TPN is significantly better in terms of mortality, morbidity, fewer septic complications, less multi-organ failure, faster return of bowel function, and lower hospital costs. So certainly some sort of enteral feeding is an important part of the management of these patients. And lastly, it's important to think about the pancreatic duct as well. Draining a collection like this is very efficacious, but if there is a disruption in the pancreatic duct, then once you take your drainage stent out, it's likely that that collection will recur unless the pancreatic duct leak is treated at the same time. And I will just end here with an algorithm from my institution. This is what we use for patients with pancreatitis who come in with pancreatic fluid collections. As you can see, depending on the type of collection, dictates the type of therapy, whether it's endoscopic drainage plus enteral feeding versus necrosectomy plus enteral feeding versus just enteral feeding alone for poorly organized fluid collections. So in summary, the revised Atlanta criteria for fluid collections divides both acute and chronic collections into categories based on the presence of necrosis. Pancreatic fluid collections should be drained only in the presence of symptoms or complications. Size alone is not an indication for drainage. The drainage approach is dependent on multiple factors, but in the majority of cases, endoscopic EUS-guided drainage is the preferred technique. Walled-off necrosis may also require direct endoscopic necrosectomy, and think about enteral feeding and pancreatic duct exploration in conjunction with pancreatic fluid collection drainage. Thank you so much for your attention.